Good morning. Welcome, everyone. I'm Keith Seinfeld from Public Health, Seattle and King County. Happy May Day if you're paying attention. It's a day, incidentally, when we are aware of and honoring our immigrant and refugee communities, and it's highly appropriate for today. I'm Keith Seinfeld from Public Health, Seattle and King County. This is a news conference about some updated data that we have and other information about COVID-19 cases, hospitalizations and deaths by race and ethnicity. We're seeing some pronounced inequities in how COVID-19 is impacting our communities, and we'll be hearing about that today. Our agenda includes two speakers, Dr. Jeff Duchin and Matías Valenzuela. I'll introduce them more formally in a moment. We will have an opportunity for media to ask questions. That's an important part of what we're here for today for this news conference. The way to ask questions is to type them in the chat box in Zoom. The moderator then will, our moderator team here will select questions and we'll get through as many of them as possible. We can't promise to ask all of the questions, but at any time during the news conference today, you can type in those questions. At 11:45, we're going to stop the English language portion of this news conference, and we'll have a Spanish-only portion with Matías answering questions in Spanish from Spanish language media, and you're welcome to stay on for that if you would like. So without further, let me remind you one other thing. The data that we will be discussing today has been published in two places on the Public Health website. We have a blog that you should find at Public Health Insider, publichealthinsider.com, and it's the most prominent new blog on there. You'll find it easily. And within that, there's also a link to additional data on a data dashboard. And we'll be discussing all of that today. And it'll have most of the key messages you need. And if you're scrambling to get numbers, all the numbers are either in the blog or on the dashboard. So you'll be able to get them all there. So without further ado, let me introduce Dr. Jeff Duchin, is the health officer for Public Health, Seattle and King County. If you need to spell that, it's J-E-F-F and capital D-U-C-H-I-N. Jeff, why don't you take it from here?
Thank you, Keith, and thank you everyone for joining today. We're going to be sharing with you information from a new analysis of COVID-19 cases, hospitalizations, and deaths by race and ethnicity. And I want to start by sending our sincere condolences and sympathy to everyone in the community who's been impacted by this unprecedented and terrible outbreak. We are really still at the beginning of this ordeal. It's going to be with us and challenging us for many more months. The updated data that we're going to be sharing with you today show that in King County, COVID-19 is disproportionately impacting communities of color. As of yesterday, there were a total of 6,280 cases in King County with 441 deaths. Among all of these cases, for Hispanics and Native Hawaiian Pacific Islanders, the rate of reported COVID-19 disease is 4 times higher than it is for whites. The rate of reported COVID-19 cases for blacks is double the rate for whites. Rates are also higher for American Indian and Alaska Native populations, but because the total number of cases in this group is very low, 29 in all, the rate is not statistically significantly higher. The rate of reported COVID-19 cases for Asians is similar to that in whites. I'm now going to share information about hospitalizations. Compared to whites, Hispanics were found to be 4 times more likely to be hospitalized. Rates were also significantly higher for Native Hawaiian Pacific Islanders and for blacks as compared to whites. With respect to deaths, again, I really want to emphasize that we are in solidarity and sending our sincere condolences and sympathy to all those who have lost family, loved ones, friends in the community. Are we still good with the video? I'm going to take a pause here for a sec. We are? Okay. We've had 441 deaths in King County, and although 297 have occurred among whites and 34 among Hispanics, the rate of death is higher among Hispanics. It's about 2.5 times higher compared to whites. As the outbreak evolves, the percent of cases by race and ethnicity appear to be shifting, and the disparities are becoming increasingly apparent. For example, over the past month, the proportion of COVID-19 cases among whites has decreased, while the proportion of cases among communities of color has increased. And this trend is consistent with the evolution from many of our initial cases being associated with long-term care, skilled nursing facilities, to more transmission and cases in the larger community. I should also note that although I mentioned that the rate of death from COVID-19 is 2.5 times higher for Hispanics compared to whites, I should have also let you know that for other racial and ethnic groups, there were no statistically significant differences. The reasons we're seeing some of these disparities are multiple. For example, different racial and ethnic groups may differ in their access to testing, in their access to healthcare, or in their healthcare seeking behavior. And they may have different risk factors for infection related to the type of work they do, their household size, and other exposures in the community. We need to learn more about this. All of this in turn affects whether someone will be diagnosed with COVID-19 or reported to us, or perhaps at what stage in illness they become diagnosed. Early in illness, where healthcare may be available, or later in illness, where treatment may be more difficult. The bottom line is we need to work with our community partners to help us understand the risk factors for continuing COVID-19 cases that are leading to these disparities, and to identify steps we can take to decrease these problems. For more discussion of this, I'm going to turn the podium over to my colleague Matías Valenzuela.
Keith, were you going to say anything, or I should just start? Thanks.
Sorry, we're managing the muting and unmuting here is a new exercise, and it's kind of a fun little game. Let me introduce Matías. Matías Valenzuela is the Equity Director for Public Health, Seattle and King County, and Director of the Community Mitigation and Recovery Branch in our COVID-19 response. Matías is spelled capital M-A-T-I-A-S and Valenzuela, capital V-A-L-E-N-Z-U-E-L-A. Matías, go ahead.
Thank you, Keith. And also, like Dr. Duchin, I want to express my condolences, and also just recognize the very challenging situation that our community continues to go through. And these are, in fact, yes, very sobering new information and updated information that we are sharing. The latest data confirms what so many of us here in public health and in our communities have been concerned about, and that's that the tragic reality that this disease is actually exacerbating other inequities. It is putting people in harm's way and a greater exposure to not just COVID-19, but to the social and economic impacts of the crisis. We have more to learn about the impacts of COVID-19 in terms of Black, Indigenous, Native, communities of color in general, but I think it's important also that there's a lot that we do know. There are things such as around healthcare that our communities of color lack access. This is coupled with more need for more culturally responsive healthcare. If we look at particular communities that we're talking about today, for example, undocumented people, we know that they're not covered by federal health programs. So very serious barriers coupled with issues such as distrust of systems and the healthcare system. We also know there are underlying health conditions that at the end make people more susceptible to death and complications from COVID-19. So people with underlying health conditions, and these conditions include heart disease, diabetes, severe obesity, and the prevalence of these is higher among our communities of color. And there are root causes of this as well. So when we think about what are the root causes of disease, we talk about the social determinants of health or the determinants of equity. These are things such as access to good paying jobs, to good schools, to healthy environments, to places where people can exercise, strong neighborhoods. Those are all root causes of this. So we're talking very much about structural and systemic issues that are at play. We also, there are issues specific to the living and working conditions which affect, have impact in terms of COVID-19 as well. More communities of color, for example, live in multi-generational housing. That makes it difficult to physically distance if a person is positive for COVID-19, and can lead to more infections. If they're positive, they come back to their household, to more infections to those who are in their households. Also, this is critical, and it also explains some of the shift that we're seeing from some of the early cases in long-term care facilities to what we're seeing now is what we're seeing also in terms of who are the essential workers, who are those people who are having to go out and work during these challenging times. These are disproportionate, the numbers are disproportionately people of color. They're also, for this reason, that they're going out to work, have greater potential for exposure and are not able to physically distance like others. Just as I talk about essential workers, also just recognize, and as Keith said as we were opening this, that this is May Day, and really recognize the sacrifices that many, I think so important both in terms of the healthcare providers and the deep recognition that has been made of them and their work during this. But there's also a whole set of other essential workers that are, literally also putting themselves in very vulnerable situations. Frontline workers, many of them immigrants and refugees in low-paid positions. And I thank them here on May Day for their historic or their very brave, heroic work that they're doing. But we need to be responsive, and this is where public health, working with our community partners, we need to continue to do work. I've done some things, and since the very beginning of this pandemic, we convened a pandemic community advisory group, and we meet weekly, we have dialogues, we provide information, and most importantly though, we actually ask for their input and their guidance in terms of how we should be responding and what are the things that we should be paying attention to. There are things, Dr. Duchin spoke about access to testing, and these are things that they've been talking to us about. Also issues around mental health. Also, many of the things that we're seeing are not just COVID specific, but there are the broader issues, basic needs such as food, housing, rental assistance. And then the issue also that I think we're highlighting today, how do we continue to prioritize and protect workers on the front lines and the families of those who are most vulnerable? I think that's going to continue to be an area of a lot of our concern moving forward. Our goal, of course, is to ensure that all communities in King County have both the knowledge, the information, and the resources to be able to stay safe and healthy during these times. But we still have a ways to go. Public health, the branch that I lead, convenes task forces to reach sectors and organizations with the tools and resources to manage COVID-19 when people are exposed, and then how to implement physical distancing in different situations, address emerging issues such as mental health or economic impacts. We are focused our work in terms of the most vulnerable populations, communities of color, immigrant refugees, and then look at specific sectors such as the faith-based communities, small businesses, housing providers, older adults, and people with disabilities. We've also, given what we've been hearing from community and the concern how to get deeper into communities, we also have developed Speakers Bureau. We're working with community navigators who are helping get the information out. So communities can really get this information in culturally relevant ways and also get it from people that they trust, messengers from the communities. We're going to continue to do that, and also working with some of our philanthropic partners so they continue to fund our community leaders and organizations that are doing this great work. It's critical to have those people out in the community and reaching through those trusted networks. We're providing some of the basic infrastructures to support that, such as with language access. We regularly translate our materials into 21 languages. We've also have, as part of our new public service campaign, we have translated some of those videos and materials into 11 languages, but we need to do more. And this is why we're really trying to highlight this. We need to support our essential workers and their families, particularly those who can't stay home and are bringing bread to their home and food. As Jeff mentioned, we need to focus on testing for communities and those who've had less access and working with those providers. And then we need to continue to partner with our community-based organizations and their leaders to support the resilience that exists in those communities and the real knowledge and power that exists there. So with that, I'll turn it back to Keith.
Thank you, Matías. So we have time now for some questions from the media. We've had a number of questions entered into the chat box. Just as a reminder, that's the way to get your questions to us, through the chat box in Zoom, and we'll get to as many as we can. First up is a question. The first two questions are directed to Jeff Duchin, and then we have one that's a broader question after that. So first up, Jeff, this is a question from Anne at KUOW. She's asking about what's enabling this new analysis of ours. Is it because demographic data is more thoroughly collected than it was previously in order to allow us to get the more robust data?
Can you hear me now?
Yep, we got you.
Thanks for the question. Very important. So as you know, currently in Washington State, race and ethnicity data are not required to be reported to health jurisdictions as part of our notifiable disease reporting. And I just want to let you know that the State Board of Health is now considering making that race and ethnicity information part of the required reporting. And we very much support that. Our King County Board of Health has supported that. And if others are interested, there is an opportunity to express your opinion about the importance of reporting this information on the State Board of Health website. So back to your question, because it's not required, much of the information we get through our case reports is incomplete with race and ethnicity data. We've done a number of things to try and improve that. We've matched our notifiable disease reporting data with other data sets, and we've also scrutinized medical records for information that might not have been part of the initial report. So we're pulling together several data streams to decrease the number of unknown reports with case and ethnicity data. Nevertheless, a significant chunk still remain unknown, and we're hoping that the State Board of Health will help us by requiring this information going forward. The other thing that's enabled us to do this new analysis is just increasing numbers of cases. It's very hard to find differences among groups when there are not that many cases overall, or when most of them are concentrated in one group, as we saw initially with our outbreak focused on many long-term care facilities. But as time has gone on and the outbreak has evolved, we've seen more community spread and gradual increase in the number of other types of people from different communities who are becoming infected. And we have a large enough database now that we can do these analyses with supplemental matching of race and ethnicity data.
Thanks, Jeff. We have one more sort of technical question. When you're talking about death rates, are we comparing to the population, or are we comparing positive COVID cases within each demographic? In other words, this is from David at Crosscut. In other words, is a Latino person 2.5 times more likely to die, or are COVID deaths 2.5 times more prevalent?
The complete and detailed information is available on our data dashboard, and you can link to that from our blog. The data that I shared with you is the relative risk of death among patients who have COVID-19. So among all the patients who have COVID-19, we have done an age adjustment and compared the rates of death in the different racial and ethnic groups.
Thank you. This is a question from Pablo at Univision. He's asking about why, and this is probably for both Matías and for Jeff, about why the percentage of Hispanic cases has been rising while as a percentage compared to whites. Is social distancing a reason? And what steps have we taken to address this? And I don't know, who wants to go first on that?
I can start. I mean, one of the things we've been talking about is the issue around the shift, and now from the focus on long-term care facilities to then see what is actually happening within the community. So we know now that people that are Latino, for example, Pacific Islanders, others who are essential workers, are putting themselves in harm's way. This is not an easy issue in the sense that we knew, and I would say, I mean, I've been focusing around equity and social justice, and we've been launching our work now I've been doing it for about 12 years. And we know that the root causes and underlying issues that really drive the outcomes that we see across all diseases. So actually, if we're able to now, through the new dashboard that we've created, we're able to see how COVID begins to play out in terms of cases. And it looks very similar, sadly, to what we see in terms of where we have our communities of color, where we have our low-income populations, where we have our limited English-speaking populations, where we also have higher rates of all kinds of chronic diseases. So this is, and also other things such as sometimes health hazards or environmental hazards and those kinds of things. So there are underlying issues that drive these. And then also in terms of not having access to good schools and good paying jobs and those kinds of things. So they're really important to have the root causes. So I think this is something that is not just specific to King County. It's something that is part of a national, even international issue here. And in King County, we've been trying to prioritize this, and especially being able to provide the data and the ways that are really useful. In terms of the work that we're doing, I think there's a lot of things. We have, task forces. We have some within our group, and the work that we're doing, we have some folks specific to the Spanish-speaking population, because that's what was being asked about. We have people that are doing very targeted work and focused work on those communities. There has been funding through some local philanthropic organizations to support those communities. And I think all those efforts have been important. But then at the same time, the need is so great that we're only able to meet a fraction of the need. So I think one of the things that we've been able to see also is through our call center that the proportion of folks who are limited English speaking who are asking to use an interpreter has been relatively low. So I would say that that's a marker, or that's telling us that we need to do more to get the word out. And we want to encourage our non-English speaking population and other communities of color to actually call in if they have any concerns around symptoms and or just COVID in general. And so because we want to make sure that these complicated situations in which you actually have an essential worker, they're coming home, if somebody is positive, that the correct steps are doing and that they have the information they need to be able to keep others and their families and their surroundings safe. So I'll keep it at that.
Jeff, did you want to add anything to the question about why the percentage of Hispanic cases has continued to rise?
Yeah, so it's a complex issue. There are probably many factors. Part of it is the way the outbreak has evolved as it enters our community and spreads. Part of it is probably something to do with testing availability. We know we don't have testing equitably distributed throughout our community currently, but it's becoming increasingly more available. And as we have more testing coming into communities of color, we expect to find more cases in those communities, and we hope people who are ill with symptoms of COVID seek testing. Of course, we also want them to isolate themselves and make sure that their family members stay home until we know if they've been infected or not. But part of this is due to artifact of testing availability. And then some of the things Matías spoke about. We know that we have a higher proportion, relatively speaking, of Hispanic ethnicity of people in some of these frontline essential worker categories who are helping us keep our society functioning. And these people are taking some risks to do that on behalf of all of us. So that's another factor that's likely involved. But we will try and learn as much as we can from our case interviews. We're going to try and gather more information from the people themselves who are infected to learn more about the circumstances of their infections, what they do for work, and how they may interact with others who have COVID, so that we can design strategies to decrease the amount of infection in our community. As you know, we're still seeing way too many cases, and we're going to need to further decrease the number of cases before we can comfortably relax our current social distancing. So the only way we're going to be able to release the only way we're going to be able to further suppress the number of cases is by understanding more about how people are getting infected, because we've stalled out now and we're seeing a stable number of cases coming in for many weeks, and we need to get that number much lower. The only way we can do that is by learning more about how people are getting infected and put a stop to it.
Thank you. We have a question from Lewis at the Seattle Times. He's asking, how do the findings from King County compare to similar studies elsewhere in the state or elsewhere across the nation? The race and ethnicity data.
Do you want to start, or would you like me to?
I can say something. I mean, these are general numbers that I think are being seen, and we already earlier on April 10th we released some preliminary findings. So I think these were trends that we were already seeing early on, and these just kind of reconfirm the things that we've been seeing. But there are areas around the country that are seeing very similar trends, but they don't all look the same, and I think that's just due to the composition and the population of each place. But this is common now as states begin to report this, or metro areas begin to report this. There are areas around the country that are showing the highest levels in terms of rates in cases around the African American population. And as we've been talking about here in King County, we are seeing most of, and especially in the Native Hawaiian, Pacific Islander, and Hispanic Latinx population. So there are differences and national differences in terms of what we're seeing, but in terms of seeing these disparities play out, it's a national phenomenon.
Next question. Sorry, next question. Next question is about methodology. So I guess this is a Jeff question from Michelle Brookman. Can you tell us a little bit about the methodology, specifically about identification? Are people self-identifying their race, or how do we know what race or ethnicity people are or have?
Yes, thank you. Ethnicity can be self-identified through a case interview, or we can derive it from another database where it might be classified by a healthcare provider, for example, or a database that does Medicaid. But I'm not exactly sure how that would get classified. I imagine it's self-identified as well. But I think you're getting at an important point. You know, these classifications are somewhat arbitrary, and they group together people that are different. Even the categories that we have, for example, not all Hispanic people are the same culture, come from the same communities, or have the same behaviors. Similarly, with Black, there are a variety of different Black communities from different cultural groups, from different ancestries, who are not all part of the same community necessarily, and may not all have the same risk factors. Same with Asian. So there are some limitations to the classifications that we have that are, don't tell us everything we need to know about how people may be affected in our community, and finer stratification of risk according to more realistic classifications. And that's some of what we hope to get at through the enhanced interviews. And by the way, we've been working with our colleagues at Washington State Department of Health to change the way interviews are done to collect more of the information that will help us better understand risk for each individual in order to decrease transmission going forward.
Thank you. We have a question from John at KOW about air pollution. It's directed to Matías. We all know air pollution can damage lung health, and he cites places like Duwamish Village that have both worse air pollution and large communities of color. So what does inequity in air pollution mean for the COVID-19 threat? And related to that, does our data even drill down to the neighborhood level?
Yeah, so I mean, as I was saying, those areas where we do see environmental justice issues, such as air pollution or other toxins, is tending to show also where we are seeing more cases. So I think through the great analysis that has been able to be done through Jeff Duchin's shop We do have that kind of information that we're able to look at it at a census tract level. And what we begin to see is that there's some areas, such as what was just named in South Seattle, South King County, areas of very north King County, and then pockets out on the northeast side too, where we are seeing higher rates. So I think there is, it's a complicated set of factors that contribute to this. There are many contributors, but I think they're all, once you start putting all of these things together and begin to address the systemic and environmental issues that are involved, and then you bring something like a very dangerous virus that people don't have immunity to, we begin to see the situation that we have now, and certain populations are more at risk. So we're seeing that at play here. So yes, in that particular community, that would be considered, in terms of the Seattle area at least, it's an area of higher concern.
Jeff, do you want to add anything about data at neighborhood level? We've had several questions asking about whether we can get neighborhood, racial and neighborhood data combined.
We will be sharing maps by census tract, and we'll go to the smallest geographic area possible that's meaningful. Again, you know, with only a few cases in a neighborhood, you can't really make meaningful comparisons if we break the geographic areas down too small. So hopefully some of the maps that we'll be putting up in the next week or so with some more data that is more detailed will answer some of the questions that you're wondering about with respect to neighborhood. But it is always challenging to make mathematical calculations that are significant when the numbers become too small and get the neighborhoods too small.
Thank you. We have a question from Abigail at the Washington Post. It's a kind of a double question here, and I think this would start with Jeff. Can you speak, or maybe Matías, I don't know. Can you speak more about the rates of cases and deaths in undocumented communities? And part two of the question is about essential worker roles being held by Hispanics. Can you speak a little bit more about concern about that? So rates amongst the undocumented communities and the role of being an essential worker.
Let me just start by saying we don't collect information on documentation, so we can't provide an analysis of that. Matías may have some other information from his community work. With respect to essential occupations, yeah, we're looking carefully at this information currently. I expect we'll have another analysis to share with you in a number of days about that. But just on first blush and raw analysis, not really ready enough to share. We do see that, for example, a higher proportion of people in some of the essential frontline service industries that are allowing our community to continue to function during this crisis, belong to communities of color compared to white communities. And we're going to try and do that stratification. It's a little bit time consuming because the information about occupation is really not collected in a standardized way, and we have to go through the free text fields for all the reported cases, classify it, and then compare it. And we need to also control for other risk factors like household size, or whether the person is a healthcare worker or has been in contact with a known case, et cetera. But I can tell you that just on first blush, what we're seeing here is consistent with what you can find in national data about the racial and ethnic distribution of service industry workers. That's readily available online.
Yeah, I will add, in addition to what Dr. Duchin just said. I mean, there are some of the policy concerns that that are concerned about is, and these are kind of driving some of these trends as well, is, for example, we know that undocumented, in King County, we estimate we have anywhere between 70 to 80,000 undocumented people. So we know also that they don't qualify for some of the same services and benefits that others in our population. For example, the federal health programs they don't qualify for. right now too, they don't qualify for the stimulus funding that came to many of the households. So what this means is in each of those areas, you can think of how in terms of accessing care, and we know it's, that the concern about delaying care and specifically undocumented people waiting to a stage that it's going to be too late to access care. So that's a big concern. Also, just not being able to get the stimulus funding, for example, is going to be something that makes it harder to physically distance and to stay at home. So we know those are all challenging issues that add to this. And we know also, I mean, our undocumented communities are living in a very challenging situations in which sometimes we want to make sure that people are able to, if there's situations that are worrisome, like in a business where they're being made, and we've heard these reports of this sometimes about business where some employees are being forced to work even if they're sick, and we're following up on those things. But we need to be able to have people who can come out of the shadows and actually report those things and let us know. But we have undocumented populations of particular concern because they are at risk for so many things, and they have rightly so, a concern about contacting authorities around issues of concern.
Thank you. We have a question. I don't know which of you is better to address this one. Are COVID-19 patients who are Hispanic seeking medical care later than whites? And part two of the question has to do with nursing homes. So hospitalization, are they seeking medical care later than whites? And do we have a racial or ethnic breakdown for our nursing homes?
Okay, I'll start. So the question is very astute. We are looking at the interval between diagnosis date and hospitalization, and we're also looking at the interval between symptom onset and diagnosis. And we're going to be comparing those intervals across our population subgroups. So that analysis is in progress. But it clearly is a theory that we have, as you do. We wonder about whether people may be seeking care later, both to be tested and then possibly to seek treatment when they become ill enough that they feel like they need to be hospitalized, perhaps. And so early testing, early identification, theoretically, could lead to better outcomes. And so this is a theory that we're looking into as well. What was the first part question?
The other part was, do we have a breakdown by race of nursing home? Nursing homes. So we mentioned.
I don't have it handy. I'll have to get it to you. Predominantly white race, but I don't have the precise numbers, but we can easily provide that to you and follow up.
Great. We have a question from Tammy at Como. Given the sobering statistics, how do you feel about reopening? Do you think it's going too fast given that we can't get access to critical testing?
Well, one of the preconditions of reopening has always been and should continue to be widespread equitable access of testing throughout our community so that anyone who is ill, needs testing or desires testing, can get it. And recently, the Washington State Department of Health lowered or liberalized the criteria for testing so that we are encouraging people who don't necessarily need hospitalization to be tested. And that was previously recommended for people who had more severe symptoms. So we want more people to be tested, and we want more access to testing. That is a critical element before we want to see any relaxing of our current distancing that could lead to more cases. In addition, we really want to emphasize that there are too many cases occurring right now for us to start thinking about relaxing our distancing. We need to get down to a much lower number of cases before we can do this comfortably. And in order to get down to a much lower number of cases, we need to have a better understanding of the circumstances under which people are getting infected. And so that's going to take a couple of weeks at a minimum.
I'll just add, in addition to what Dr. Duchin said too, is I think the concern beyond the wide access of testing is personal protective equipment. So there has been a prioritization and rightly so, around some of the top tiers in terms of healthcare and medical providers and frontline health workers too. But we, as the supply has been tight, we also haven't been able to prioritize some of the populations that we've been talking about, some of the essential workers. So I think that's also something that's going to be increasingly of a concern for us and needs to be more widely available.
If I can just add to that important point, the personal protective equipment shortages really also impact our ability to do testing in the community, because the healthcare providers need to have that equipment in order to perform certain tests. So to the extent that we can't get the appropriate masks, gowns, eye protection out to those frontline community healthcare providers, we won't be able to do the testing that we need to do. So it's all tied together.
Thank you. We have time for one last question before we go into the Spanish-only portion of the news conference. You've already spoken, both of you, to this question to some degree, so let's just, I'm going to reframe it slightly. This is from Lily at Crosscut. She's wondering what we are doing to lessen the impact on communities of color when inequities have existed for these communities for so long. We mentioned people receiving information in Spanish and other languages, but what further could we do or would we like to do to lessen the impacts?
So let me start, and I think this is really in Matías's ballpark. He should provide a more detailed answer, but I just want to acknowledge that no one should be surprised that we're seeing these disparities in COVID-19 disease. It's been an ongoing national tragedy and a shame that we have had communities of color throughout our country suffering disproportionate adverse health impacts from a wide variety of health conditions. This has been widely recognized and tolerated for such a long time. And it is no different with COVID-19. And if you were not aware of that, you've probably been living in a cave. We really have, as a nation, to come together to address this problem through a variety of different approaches. And I'll let Matías go into detail because he concentrates on that work here at Public Health Salem and King County.
Yeah, I mean, I think we've been, touching on it, and I think there are things that can be done at all different levels. We have also supported here in King County, as there is ideas and work at the state level to look at, for example, funding specifically to support undocumented individuals during these tough times, making sure that access to testing, that some of the policy issues that there aren't barriers for immigrant refugees to be able to access. And I think a lot of those things now are in motion and they're to support. But I think, those who work in this field and have been paying attention now for decades around health inequities, this is not surprising. When this first started, this COVID-19, and we had the first cases, I knew that this was going to be growing. Knew that this was going to be devastating at the local and national scale. So these are things that have been built into our system, and what we are just basically seeing is a rehash or just a mirroring of the same maps and those communities that we see for every other disease. So what it does take is a community-wide response. It's not just about information, and it's about addressing some of the big issues. I mean, when we are having to stay home, and we use that phrase, and stay sheltered, it means something very different from somebody who can begin to telecommute versus somebody who needs to go to work to earn their money to be able to feed their families. And then those people are coming back to be able to then put their own families at risk if they have been exposed. So these are, it's not just, public health or government response. We need everybody. We need the business sector. We need everybody else working together to really address these. And to address this, not just for COVID, but thinking about what are these opportunities that we have right now to change our systems and transform the way we do our work. So I think some of the things that potentially, if we can get reporting by race at the state level for all diseases, that's a huge plus and put us in much better positions for diseases for time to come. If we can get better information around language access, we know that we're seeing similar, we don't have comprehensive data, but we know folks also have a similar type of situation around language access on those who are limited English speaking. So it's gonna take a long time to do this, but I think we need to grasp the moment today to actually figure out how we address this to both lessen the impact in this particular emergency that we have right now, but then for everything else that's going to be happening in future years.
Can I add one or two things? So thanks for that great summary, Matías. A few things that are happening here in King County, and really this has to be, you know, a bottom-up and a top-down approach to address inequities in our culture. And, you know, healthcare for all, for example, would be a great step forward. We have to address the educational system. We have to address, you know, systemic and institutional racism. We have to look at economic supports, and we have to look at educational and economic opportunities. And just to mention two big things that are happening here locally in King County is our Communities of Opportunity project, which focuses resource and empowerment and opportunity development in historically underserved communities where inequities have been located, and also our Best Starts for Kids program, because we know that the investment in early childhood education and opportunities and nurturing improves the trajectory of that child's health and economic well-being throughout their lifespan. So there are some things that we're doing here on the ground. We're continuing to try and learn how we can do more. And we really need to have the national dialogue change as well to recognize this as a national priority.
Thank you, Dr. Jeff Duchin. Thank you, Matías Valenzuela. I want to remind people that all of this data is available on a new dashboard on the Public Health Seattle and King County website. And the key points we've been discussing are at Public Health Insider. We shared the link through the chat side, and you can find that on our webpage. This is the end of the English part of the news conference. We're going to switch into a Spanish-only portion of the news conference, and we will welcome questions directly from our reporters who are Spanish-speaking. So I'm going to pause just for a moment as a few of us are going to leave the meeting, and Matías will be able to field those questions directly. And again, just a reminder, all of the data and many of the key points are available at the Public Health website.
Hola, buenos días. Mi nombre es Matías Valenzuela, soy el director de Equidad para el Departamento de Salud Pública de Seattle y el Condado de King. También en esta respuesta de COVID-19 yo soy el director de mitigación y recuperación de la comunidad. Entonces, una rama grande que está trabajando con diferentes sectores de la comunidad. Son escuelas, universidades, organizaciones de base, grupos religiosos, con sectores de viviendas, de cuidado de niños, de guarderías, de negocios y pequeños negocios y todo eso. Lo que voy a hacer ahora es hablar un poco más sobre lo que estamos viendo en cuanto y repetir un poco de lo que ya habíamos hablado en inglés. Y de principio decir que estamos también siempre aquí lamentando también los casos y las muertes y las hospitalizaciones que hemos tenido en nuestro condado. Sabemos que estos son momentos muy difíciles para nuestra comunidad. Solo hoy, digamos, los nuevos datos que tenemos 6,348 casos en el condado de King y 446 muertes. La noticia que tenemos hoy y lo que estamos compartiendo es que sabemos que, eso sí, que no todas las comunidades están siendo de manera igual impactada por el COVID-19. Si miramos especialmente a lo que es la comunidad latina, hispana, y también lo que es la comunidad isleña del Pacífico, sabemos que la tasa de casos es 4 veces mayor que la tasa que vemos entre los blancos. Lo voy a repetir, que la tasa de infección y de casos entre la comunidad latina y la comunidad hispana y los isleños del Pacífico también es 4 veces más alta entre este grupo que los blancos. Entonces, esto es un tema de mucha preocupación para nosotros. También sabemos que hay otros grupos raciales y étnicos que están siendo impactadas. Por ejemplo, la comunidad afroamericana tiene una tasa 2 veces mayor que la tasa de los blancos. Si miramos también, eso eran los casos confirmados, si miramos el tema de hospitalizaciones, sabemos que entre los latinos hispanos tenemos un índice, una tasa 4 veces mayor que la comunidad blanca. También estamos viendo dentro de otros grupos, no son índices tan altos también en cuanto a hospitalizaciones, pero sabemos que en la comunidad entre la comunidad negra, afroamericana, y también entre la comunidad isleña del Pacífico también tenemos índices más altos, pero no son tan altos como la comunidad hispana. En cuanto a las muertes, tenemos desigualdades muy importantes. Tenemos el índice o la diferencia es la más grande entre la comunidad latina, comparada con los blancos. Entonces estamos teniendo casos, es más del doble en cuanto a la tasa de muertes. Por esto hay muchas razones por todo esto, en cuanto a lo que está pasando. Una de las cosas, eso sí, en parte en la área de salud específicamente, sabemos que el acceso a pruebas es sumamente importante. Entonces nosotros en Salud Pública de Seattle, del Condado de King, estamos haciendo esfuerzos importantes para trabajar con nuestras clínicas comunitarias para ofrecer en los siguientes días más oportunidades para que la gente pueda tener acceso dentro de las comunidades para poder acceder a pruebas de COVID-19. Quiero también hablar sabemos los casos, pero ¿qué es lo que está pasando? ¿Qué son los temas que vemos aquí? Sabemos que tenemos áreas o tenemos barreras en cuanto a acceso a cuidado de salud y acceso a salud. Por ejemplo, sabemos que la gente indocumentada no tiene acceso de la misma manera que otras personas. Hay barreras en cuanto a seguro médico. También sabemos que ciertas comunidades tienen condiciones de salud que son a niveles más altos que otras comunidades. Por ejemplo, niveles, y esto existe entre latinos, también entre los negros o los afroamericanos, entre los isleños pacíficos, por ejemplo, entre los nativos también, los indígenas, que tienen índices o más posibilidades de tener enfermedades crónicas, problemas del corazón, diabetes, asma, problemas cardíacos. Esos son causados por factores, digamos, del ambiente, sociales, sistemáticos, en el sentido de que las personas no tienen el mismo nivel de cantidad de acceso a educación y a escuelas y buenos trabajos, pero también en los vecindarios no hay buenas comidas, no hay posibilidad de salir porque hay barrios que son menos seguros. Entonces hay problemas bastante profundos que están detrás de esto, que empiezan a explicar por qué estamos viendo estas diferencias. También algo muy importante también es las condiciones para las personas donde trabajan y cómo viven. Hemos estado viendo también que las comunidades de color, incluyendo los latinos y los afroamericanos y otros, viven es más probable entre los latinos, por ejemplo, que la gente viva entre múltiples generaciones dentro de una casa. Incluso yo sé que existen muchos casos también que pueden tener más de una familia viviendo en una casa, en un apartamento. Entonces vivimos muchas veces en ambientes bastante cerrados. Lo que pasa también es como nosotros tenemos en nuestro sector, especialmente los latinos, tenemos un alto nivel de trabajadores esenciales. Entonces lo que sabemos es que muchos de nuestros familiares están teniendo que salir lo que si trabajan en un restaurante, si trabajan en el área de transporte, si trabajan en el área de limpieza. Todo este sector son considerados, trabajan en mercados. Estos son considerados sectores esenciales, igualmente como los hospitales y otros. Y estos son lugares que siguen funcionando. Entonces, en esos casos tenemos a personas que están teniendo que ir a trabajar y a veces se están exponiendo más al virus que otras personas, las que tienen el privilegio en sí de poder quedarse en casa. Y después, cuando regresan a sus casas, esas personas están poniendo en riesgo a personas que están en sus familias o también que comparten vivienda con ellos. Entonces, esto está creando una situación bastante adversa, y también pensamos que son algunas de las condiciones que están contribuyendo a los índices más altos de infección y enfermedad. Hay muchas cosas que nosotros estamos haciendo aquí en salud pública para este tema, pero y puedo hablar un poco más de eso. Hablé un poco de las pruebas que se están haciendo. Estamos trabajando mucho con comunidades, organizaciones de base y otros para poder compartir información y para que la gente pueda ir a sus doctores, puedan llamarnos. Nosotros en salud pública tenemos un número de información donde gente puede llamar, que los que tienen preocupaciones, inquietudes en cuanto a su propia salud. Y es importante porque hemos visto que ahí tenemos índices bastante bajos, hay poca gente que está llamando para conseguir información sobre COVID-19. Entonces nosotros queremos seguir informando, asegurándonos que la gente tenga la confianza de llamar y conseguir la ayuda que necesiten y la información que necesitan. Van a haber más posibilidades de hacerse la prueba ahora en los siguientes días y semanas. Entonces, si gente siente inquietudes, tiene preguntas, que llamen a su proveedor médico o que llamen a salud pública. Con eso lo voy a dejar todo y vamos a tomar un tiempo para tomar algunas preguntas. Yo creo que ya tenemos a ver, una pregunta de Pablo Gaviria con Univisión. ¿Qué tipo de medidas ha tomado el condado para enfrentar la disparidad en raza y etnia? Y que puede explicar en español qué dicen los nuevos datos. Bueno, estos son algo que ya, estaba hablando. Yo creo que esta pregunta llegó cuando estábamos hablando todavía en inglés. Yo creo que esto ya lo he hablado ya. Entonces yo no sé si hay Pablo, otra pregunta que te gustaría saber en cuanto a esto, porque yo creo que ya lo hemos hablado de los datos y lo que estamos haciendo. Bueno, otra cosa que hay una pregunta que se hizo antes en inglés, yo creo que lo vamos a hablar, se habla de áreas donde aquí existe, lo que es importante saber, no solo existe esta desigualdad y un impacto mayor entre los latinos, digamos, que otros grupos, especialmente los blancos, sino que esto se está viendo también a nivel geográfico. Entonces sabemos que áreas del sur de Seattle, el sur del condado, también el norte del condado de King, áreas también del este también, zonas donde tenemos más gente de color, más gente de bajo ingreso, es también los lugares donde estamos teniendo más casos de COVID y más hospitalizaciones. Entonces, los factores ambientales son sumamente importantes. Sabemos que hay ciertos lugares y hay ciertas zonas donde la gente tiene menos acceso a cosas que nos hacen saludables, y esas mismas cosas nos crean condiciones para que nosotros estemos más probables de tener enfermedades como COVID-19. Nosotros en salud pública producimos muchos mapas y mostramos todo tipo de enfermedades, lo que es la diabetes, la asma, problemas del corazón, problemas cardíacos, etc. Y lo que estamos viendo en cuanto a geografía, si miramos los mapas que tenemos ahora en nuestra página web, bajo una nueva herramienta que hemos lanzado hoy, uno puede ver a nivel geográfico las zonas y los barrios donde tenemos más casos. Y estos son también no solo donde estamos viendo más casos ahora de COVID, pero también son las mismas zonas, las mismas áreas donde tenemos problemas ambientales, donde tenemos enfermedades más altas en cuanto a las enfermedades crónicas que estaba mencionando. Y también son los barrios o los lugares donde tenemos también menos acceso a todo tipo de cosas, de recursos que nos hacen ser más fuertes y poder aguantar mejor este COVID. Entonces, hay diferentes números que podemos dar por si la gente quiere tener acceso o quiere llamar y conseguir información. Nosotros tenemos en salud pública de todos los días de 8 de la mañana a 7 de la tarde. Tenemos un número que es el 206-477-3977. Es el 206-477-3977. Es un número donde si uno pregunta por un intérprete, dice su idioma, espera, le pone un intérprete, ahí le van a poder dar información y contestarles sus preguntas de salud. Tenemos enfermeras ahí contestando esas llamadas y le podrán decir qué deben hacer. También es sumamente importante existen casos cuando si uno tiene, digamos, en una familia, tienen un caso positivo, hay medidas muy importantes que hay que tomar para proteger el resto de la familia. Entonces, su proveedor médico le puede dar estas indicaciones, pero también Salud Pública tiene información traducida en nuestra página web y también pueden llamar a esta información para ver qué ayuda pueden recibir y cuáles son las pautas que hay que seguir para poder proteger a otras personas en la familia. Entonces, es un número sumamente importante, el del condado 206-477-3977 con intérpretes. También hay un número si la gente está buscando cuidado médico, es el 1-800-756-5437. Si uno no tiene seguro médico, es el 1-800-756-5437. Y también tenemos otro número porque también sabemos que hay personas que a veces están en situaciones complicadas. Por ejemplo, hemos tenido casos que gente le están forzando a ir a trabajar cuando están enfermos y ahí ponen a otras personas en riesgo, sus compañeros de trabajo y compañeras de trabajo, o también pueden poner a clientes en riesgo. Entonces eso, según nuestra orden ahora, si uno tiene síntomas, si uno está enfermo, hay que quedarse en casa. O si uno está viendo también un lugar donde la gente no está siguiendo lo que son las pautas, las órdenes de distanciamiento social, puede ser cualquier tipo de negocio, hay un número donde uno puede llamar ahí, y es el 206-296-1608, es el 206-296-1608. Voy a decir otra cosa que ya que estamos dando número, otro importante número es también para la gente que son trabajadores esenciales. Estaba hablando que hay gente que está yendo a trabajar. Hay un programa que tiene el condado para darle cuidado de niños a las personas que están teniendo que ir a trabajar y en estos momentos difíciles, y hay cuidado de niños gratis. Hay un programa del condado y el número para eso es el 1-800-446-1114. Es el 1-800-446-1114. Lo último que voy a decir también, porque esto lo he escuchado mucho en la comunidad, porque es muy difícil ahora para muchas personas pagar sus alquiler, los arriendos o hipotecas, si uno tiene la suerte de tener una casa. También ahora hay un moratorio, entonces uno no pueden subir los alquileres y tampoco no pueden echar a las personas de sus casas. Entonces es importante tener esa información. También hay recursos a nivel estatal que pueden apoyar a las personas que están teniendo problemas si alguien está tratando de subir el alquiler o lo están tratando de desalojar. Yo creo que hay una pregunta más. Ok, hay una pregunta de Pablo. Sí, ya las dos primeras las cubrí, pero quiero regresar a la primera porque lo que escucho es que quieren aumentar las pruebas y tener más información disponible. ¿Hay algo más? ¿Y por qué piensan que más pruebas va a ayudar a disminuir la disparidad? Bueno, una de las cosas que, como funciona esto, las pruebas son sumamente importantes para saber quién está infectado, porque lo que pasa es que ahora lo que estamos teniendo es infecciones y transmisión en la comunidad. Entonces, una persona que, por ejemplo, se siente enferma, es sintomática, tiene que llamar rápidamente, hacerse una prueba, idealmente, y aquí va a poder también, si es positivo, se va a poder aislar. Las otras personas que han sido expuestas se van a poder poner en cuarentena. Eso en cuanto a disminuir la transmisión es crítico y la única manera que vamos a poder enfrentar esto. Entonces hay que poder identificar la gente positiva, aislarlos y después los contactos hay que ponerlos en cuarentena. Entonces cuando no hay un sistema suficiente de pruebas y la gente no se puede estar haciéndose las pruebas necesarias, entonces sabemos que hay transmisión, hay gente que es positiva, incluso gente que puede estar sintomática y hasta el momento, como no ha habido falta de pruebas, toda esa gente no se ha podido hacer la prueba de COVID-19. Entonces eso es una limitación muy grande. Entonces por eso nosotros estamos trabajando con nuestras clínicas comunitarias para buscar geográficamente en los lugares donde vive la gente latina y la otra gente que tiene necesidad, gente de bajos ingresos, para que puedan hacerse las pruebas si tienen la necesidad de hacerse unas pruebas, porque lamentablemente este ha sido un obstáculo muy grande. Ahora cuando sigamos y vamos lentamente se van a ir viendo modificaciones a las órdenes, posiblemente más gente va a estar regresando al trabajo, etcétera. Entonces va a ser sumamente importante que cuando una persona mantengamos bajo los niveles de enfermedad e infección. Y eso, tener un sistema fuerte de poder hacer las pruebas y después confirmar rápidamente, identificar todos los contactos es esencial. Entonces, una parte muy importante hasta que no tengamos una vacuna, es la herramienta y el sistema que usamos para disminuir la infección en la comunidad. Ok, bueno, con eso muchas gracias. Le agradezco la atención a este tema que para nosotros aquí en Salud Pública, yo creo que para toda la comunidad es muy importante. De nuevo, soy Matías Valenzuela aquí en Salud Pública y puedo en el futuro, si necesitan más información, pueden hablar conmigo o con gente directamente en nuestro equipo de comunicación. Muchas gracias.